Good evening, everyone. Thank you for joining us tonight at our webinar with Dr. Daniel Fassett. Today's topic will be persistent pain after spinal fusion. And thank you, Dr. Fassett, for hosting this webinar this evening. And without further ado, I will leave the floor to Dr. Fassett. Thank you.
Thank you, Melba. Well, we're still early, so we only have actually 7 participants on right now. We're supposed to start at 7. We
Okay, let's
have close
do.
to 30 people signed up, so let's wait, like another 4 or 5 minutes for those other folks. If anyone has questions you'd like answered, we could jump into some questions right now. You could put them into the chat, and we'll also have some time for some questions at the end. So. Yeah, we'll start at 7 o'clock sharp. It's scary when we're ahead of schedule, Melba.
Yeah. Yeah, we're 4 minutes ahead, so we'll just give everyone 4 minutes more.
I'm getting better every webinar.
Yes.
I think the first webinar I signed on was 60 seconds to spare, and this one
Yes.
I'm up to 10 minutes. That's pretty good.
Let's see. You have a couple of people already. We got 8 participants so far, so
Yeah, I just want to give everyone a chance.
that's perfect.
So since we're early, I don't want to start early,
I
but we
agree.
won't start late. We'll start right on time tonight. Hopefully my dogs don't go crazy right in the middle of the webinar, because I think my family's going to come home probably about 20 minutes, about 30 minutes.
I have
Depends
two
how long the
dogs too.
coaches talk after
They're
how
gonna
long the
start
coaches talk
barking.
after the basketball game. So we might be good. It might be an hour. But I just got the message they're winning, so that's a good thing.
Yeah, that's a good thing.
Makes for shorter post game talks.
Mm-hmm. Hmm.
All right, 2 more minutes and we'll get started. We've got a little puppy now too, and man, the small dog syndrome. Any
Oh,
sa- any sound and she barks.
oh my
This one
God.
is,
Is she a
I
little
guess
one?
you
Like,
would
is
put her.
she a small breed or
She's
is she
10,
a big breed?
10 pounds. Yeah, she's
10 pounds.
a pet golden doodle.
Oh,
So
how cute.
we have a mini golden doodle, but the mini golden doodle is close to 40 pounds. And so we got a pet this time, but I don't know if I would do. I love her. She's great, but she is, I don't know, small dogs. I think they're in fear for their life constantly. So any noise, she's like barking.
Oh. I've got 2 big ones, 78
You have 2
pounds
big ones.
and 64
That's too much
ponies.
yard waste for me.
I got ponies, little ponies.
That's a job in itself right there, cleaning up after those 2.
Yes, it is.
All right, we're getting close. 1 minute and we'll get started.
I'll tell you one thing, when I do take them to get groomed, they make quite an impression. People just walk away from me.
I'm sure. Yeah. This one is a little bit more of a guard dog, so if there's any noises, she will alert us, whereas the other dog just sleeps through everything.
Oh,
And they're here at my feet right now.
oh. 2
Go
girls?
everywhere you go. 2 girls, yeah. We don't. We have 1 boy dog. We have an incident with a biting incident, so now we're just girl dogs.
Okay.
Yeah. Testosterone does bad things.
Now I got 2 boy dogs. That's what I'm saying.
All right, I think it's 7 o'clock. We'll go ahead
All
and get
right.
started. So,
Off we go.
thanks for waiting, everyone. Appreciate you joining us tonight. I'd like to thank Melba for setting this up. And I'm going to talk about a very, very challenging issue, which is persisting pain after you've had surgery, particularly spinal fusion surgery. So just to provide a little background for myself. So I was a neurosurgeon in training. I did 6 years of residency at the University of Utah. And then from there, I did a combined orthopedic spine fellowship and a neurosurgery spine fellowship at Thomas Jefferson University with Rothman Orthopaedics in Philadelphia. It was a great experience. That's kind of how I become to know I know the people at Rothman and developed a relationship with them that prompted this job down here. I practiced neurosurgery at the University of Illinois in Peoria, Illinois, for 15 years. I was the head of neurosurgery there, the head of spine there, the head of this fellowship program. I had a lot of great experiences, but it's really good to be in Florida, particularly this time of year. So, what do I do? So I evaluate and I treat patients with spinal conditions, and I try to evaluate whether surgery is a good option for them or not. So there's many conditions, many people where surgery shouldn't be the first option, that's for sure. And then sometimes surgery shouldn't be an option at all because sometimes surgery might produce negative instead of positive results. And that can definitely occur with spinal fusions. So in terms of what treatment, what conditions I treat the entire spine from the neck, the cervical spine down to the lower back. Radiculopathy is very common. That's pinched nerves. So you've heard of radiculopathy, sciatica, same thing. Pinched nerve either producing leg pain or arm pain. Myelopathy is when arthritis is damaging the spinal cord, and there's a lot of times we're considering surgery to preserve an individual's ability to walk. Scoliosis, which is a curvature in the spine that's abnormal, can lead to disabling pain, can lead to pinched nerves. Tumors in the spine, so tumors are very common. As cancer treatments improve, more patients are surviving with cancers, and a lot of cancers spread to bones, particularly in the spine, and can cause issues with back pain and nerve compression and spinal cord compression. And then I see a ton of patients. Probably the biggest group of patients that gets referred to the spine practices are for low back pain and for neck pain. And for these patients, I would say very few of them that I'm considering surgery for, and surgery is definitely a last resort option for most of these individuals. And you'll see why in this talk. So just to orient you regarding your spine, so you have 7 cervical vertebrae. We have a curvature there in the cervical spine called lordosis, which is this curvature back. We have the thoracic spine comprised of 12 vertebrae, and then you have your rib cage. So there's not a whole lot of flexibility there in your thoracic spine. In the lumbar spine, we'll go back. In the lumbar spine, we have 5 vertebrae, and then the sacrococcygeal region. We have a lordotic curvature there in your lower back. As we age, we can lose that curvature and lean forward. And it's a common area to develop arthritis. You know, that area of spine carries a lot of forces, sees a lot of stresses in day-to-day activity and living. Between the bones in the spine, we have a canal where the spinal cord goes down through the spinal canal. And then between each of the vertebrae is what we call a foramen, where nerves are exiting the spine. And these nerves can go down into the arms and legs and provide function for muscles, also provide sensation. So nerves, particularly in the cervical region where we have a lot of flexibility, and nerves in the lower back have a propensity to develop pinched nerves, which are either from bone spurs, disc herniations, other things. And those nerves can get irritated, producing radiculopathy, as I stated earlier. So here's what our vertebrae look like. So we have 2 adjacent vertebrae. We have a disc, which is basically a shock absorber in the front between the 2 vertebrae. And then we have 2 facet joints in the back. So most areas in the spine have comprised of 3 joints, a disc and then 2 joints in the back. And cervical spine, we also have 2 other small joints called uncovertebral joints, kind of like a cup. But in general, so most disc and 2 joints, think of. And you can have arthritis in any of these areas. You can have arthritis in the disc. I'll send him a quick message. So here's the function of the spine. So here we have the disc in the front, the vertebrae, that's the spinal cord. And then you can see the nerve leaving the spine. So the function of the spinal column is to support our body weight for movement, and then protect the spinal cord and protect the nerves from damage. Here's our disc that I mentioned. So the disc is kind of designed like a radial tire. The outer part of the disc has this fibrous tissue, and it's in alternating patterns, just like a radial tire. So it's very strong. It can handle forces such as rotation. And then the inner part of the disc is kind of gelatinous, and it absorbs forces. But as we age, that inner part of the disc tends to dry out. There's very few cells within that disc. When those cells die, they no longer produce proteins. It's the proteins that attract water into the disc. So do you have disc degeneration? For most of that's a big yes. We see a lot of people by age. I see a lot of teenagers with disc herniations and disc degeneration. By age 30, I would say the vast majority of us are going to have some disc degeneration. Not all of the disc, but some of the disc. So everyone's going to have some disc degeneration. So here is a study looking at, these are normal people. Okay, these aren't patients with back pain and nerve pain and symptoms. These are normal people without complaints, asymptomatic. And if you look by age, 20s and 30s, a lot of them, over 50%, are going to have some form of degeneration. When we get up into 60s and 80s, it's 80, 90% of us. Pretty rare that we're seeing an MRI scan that's completely normal at that age. Pretty rare that we see a completely normal MRI by 30 or 40, actually. So here's kind of the cascade of events we see. We see the disc, as it deteriorates, it dries out inside, collapses, and then this is more significant degeneration. Air, nitrogen can deposit within the disc, and bone spurs can form. The body kind of tries to stabilize that segment by forming calcium in the ligaments and joints around that degenerative disc. So why does degeneration occur? A big factor is genetics. So if you have someone else in your family, your mom, your dad, your grandma, or brother and sister who've had spinal issues and spinal surgeries, you're definitely at higher risk than others to have spinal issues. So what can go wrong as we age? So we can have arthritic spinal pain, and most of us are going to experience that at some point in our life with either neck pain or low back pain. A lot of us start experiencing that in our 30s and 40s, and definitely gets more common as we get older. Can also develop issues with nerve compression, from compression of the nerves leaving the spine, what we call spinal nerves, or compression upon the spinal cord, which can produce damage in the spinal cord, resulting in coordination issues, weakness, trouble walking. So does spinal degeneration always result in pain? No. Most people live day to day, have spinal degeneration. A lot of them don't even know they have it. So they live functional lives without disabling pain. But saying that, back pain is also the second most common reason to see the primary care physician outside of the common cold. So it's very common for people to have back pain. So what is a spinal fusion? So a spinal fusion is where we're attempting to get two adjacent vertebrae to grow together. And once they grow together, they no longer move individually. So we're eliminating movement across the joints between those two vertebrae. So it involves removal of a bone surface. So we kind of clean the bone off. There's some tissue over it we call periosteum, which is some soft tissue. And then we decorticate, we remove the bone surface, and then we take bone graft, either another area from the patient, or from an area where we're doing nerve decompression, or we use a donor bone called allograft. We lay down on those surfaces, and the intention is to try to get these two bones to grow together. That's what a fusion is. A fusion takes time to occur. So in the past with fusions, 50, 60 years ago, even 30, 40 years ago, we did a lot of immobilization after fusion. So you do the fusion and you would try to immobilize patients as much as possible to improve the likelihood that those two bones would grow together. Up on top, this is an image of a individual, a teenager, getting casted after having a thoracolumbar fusion for scoliosis. They should be placed in these casts for months, 6 months oftentimes. A lot of people would be on bed rest for extended periods of time. So a fusion was a big ordeal back in those days. They had a lot of morbidity from laying around. That led to the advent of spinal instrumentation. So with instrumentation, we're creating an internal brace. So we're putting screws into vertebrae, linking those screws together with rods, and then here's a cage in front. So we basically lock everything together internally in an internal brace, so the patients no longer need to wear the external brace, and also are able to get up and move around a lot earlier after surgeries. So why are fusions performed? Well, there's some really good reasons to do fusions. There are some bad reasons to do fusions, and then there's some ugly reasons to do fusions, real ugly reasons. Fortunately, in my profession, I see a lot of I see a lot of sad stuff, and I'm sad for my profession. I see a lot of surgeons that aren't doing things for the right reasons. But let's go through some of these. So why are fusions performed? So a good reason is to stop abnormal movement or instability across the spinal joint. That's called, in this particular case, one of the more common ones called spondylolisthesis, which is a big fancy medical term that means slippage. So in this particular patient, this was a 34-year-old fireman, actually active while he was fighting a fire. He had this abnormality previously, but for whatever reason, when he was pulling on the hose, he really strained and caused an aggravation of this issue. So he has what we call an isthmic spondylolisthesis. He has some fractures here in the joints that allow for this slippage to occur. So this bone here is lumbar 4. This is lumbar 5. This one should be sitting back here in normal alignment. So they tend to line up together. This one slips forward because of that fracture and instability. So instability from something like a spondylolisthesis, typically a good reason to consider having a fusion procedure performed. Stabilized fractures in the spine. So this lady, as I remember, I think her husband fell asleep while driving. They drove off a bridge. So she presented. She had some mild head injury, so she was difficult to examine, but she seemed to have some weakness in her legs. This vertebrae here basically exploded, what we call a burst fracture. So instead of being a square rectangle, this vertebrae exploded, pushing bone fragments in towards her spinal cord and the nerves in her lower back. So to address that, we went in and created room. We removed the back of the spinal canal. We're able actually to remove a lot of that bone and push it forward. Removed a lot of it, and then we put a cage in the front where that vertebrae used to be, okay, to provide some support, what we call in the anterior column. We put screws into 2 vertebrae above and below, and then linked everything together with rods to provide stability. At the same time, we do the grafting that I mentioned before, where we're trying to get these bones to heal and grow together. Another good reason for a fusion is to prevent instability after decompression. So there's times where a patient might not have instability going into a spinal surgery, but as a surgeon, we create instability because we're trying to get the nerves decompressed to eliminate their symptoms of sciatica or nerve pain. So there's a number of different areas where nerves can get compressed. So we have what we call a center canal. Center canal is pretty easy to address with surgery. And if a patient doesn't have pre-existing stability, I can usually do a small decompression surgery there without any screws and rods, without any fusion. Issue comes along when we have foraminal stenosis. So the foramen is over here on the side, this hole where the nerve is leaving, and if that hole gets closed off, the only way to really get that open up real well is to remove these joints. So this is the foramen here. If you can see my arrow where the green nerve is leaving, that's the facet joint. So we have to remove these joints in order to get that nerve freed up. Here's an MRI of a patient. So we can see his nerve. There's his nerves below in the foramen. You see this foramen is just dark, and his bone has inflammation. So this patient had nerve pain on that side. The only way I can fix it is to remove these joints. When we start removing joints, then we're creating instability. So we do a fusion to prevent issues with that instability, prevent a second surgery. Another good reason is deformity. So if a patient has a mild deformity or a moderate deformity, we get very concerned about doing decompressions. This patient here, this is a CAT scan. Unfortunately, she had a laminectomy. She had a neurosurgeon go in and aggressively remove bone to get nerves decompressed. But now she's basically got a right angle in the lower back and disabling pain, can't stand and walk. So we have to do a fusion to straighten her spine and stabilize her spine so that we can relieve the nerve compression, relieve her back pain symptoms, and get her mobilized better. Another good reason is once you have one fusion, you tend to have more fusions. I tell my patients that, if you're going to have a fusion, I always warn them about adjacent segment degeneration. So as we remove a joint, it puts more stress on adjacent joints, and then they tend to develop issues down the road. It's a pretty common 10 to 20 years after initial fusion to have another fusion for those reasons. This gentleman, I think he's in his early 50s. He had a decent fusion here of 4-5, and at the same time, he had an experimental procedure. I don't know what the surgeon was thinking. They put these screws in, never seen anything like it before. Unfortunately, they injured nerves down here. He's had permanent weakness in his left leg, but he's lived with that weakness. He's been very functional. He's an avid bike rider. He's gotten to the point though where he can hardly walk and ride his bike because of pain. So now he's developed stenosis. So here are the nerves. The white is spinal fluid, which means there's plenty of space and cushion. If we look right here, there's no space for these nerves. So up above his fusion, he's developed an issue. He also has a little bit of a slippage, what we call spondylolisthesis. So pretty severe nerve compression there. So when we do that decompression, usually we're going to extend that fusion up because a decompression alone just can't handle all that stress. There's a lot of stress right up above the fusion, and that's what led to the problem. We try to do a decompression alone. A lot of times those patients are just going to fail within, I would say, 6 to 12 months in many situations. So I typically try to avoid that. So not so good reason to do a fusion. Not so good reasons usually are to try to cure back pain and to try to cure neck pain. And unfortunately, I see this way, way too much in my profession. So surgery, particularly fusion, is not an extremely reliable cure for back pain. I would say patients with instability from spondylolisthesis and scoliosis may do better. So I might be inclined to operate on someone with instability in their spine or scoliosis in their spine. But someone with a normal spinal alignment, some disc degeneration, it's pretty rare that I would recommend surgery to cure back pain. And then on top of that, patients with chronic pain factors do very poorly. So if someone has depression, anxiety, fibromyalgia, and has been on narcotics for years, it just makes things a lot more challenging. We know as a population, we've studied patients. If you have more of these factors, you're typically not going to do well with surgery. Now, if you have a little anxiety and you don't have, you're not on chronic narcotics and you don't have a diagnosed fibromyalgia, I'm not saying a patient with anxiety can't do well or a patient that's been on narcotics for 3 months or 6 months can't do well. But as a whole, those patients are going to have more failures with spinal fusions than other groups of patients. So if you have some of those factors, you just got to be aware about doing these surgeries. You got to be aware about what your surgeons recommended. They might not be recommended what is in your best interest because it all comes down to money. Unfortunately, spinal fusion surgeries are paid very well. Surgeons are incentivized to do spinal fusions for that reason. I see patients for second opinions that have what I think are normal MRIs, and they've been advised by another surgeon to have a fusion. And the sad state is they have that fusion, they know better, they go back to see that surgeon 3 months later, they're like, sorry, I've done everything I can. I can't offer you anything else. We're not going to schedule any more appointments. So now you've had a fusion in your back, you've undergone a big surgery, and you still have pain. And now you're set up to have another surgery as you get older due to adjacent segment problems or failure of that fusion. So, so now we get to the stage of, so you've had that fusion and you're still in pain. What do you do? So potential causes for persisting pain after fusion surgery are nerve pain, radiculopathy. So nerves might still be pinched. Your surgeon may not have done a good job of getting the nerve decompressed, or possibly there's a screw. So when we put these screws in, they go in through channels of bones we call the pedicle. Adjacent to those bones are the nerves, and occasionally a screw can get misplaced slightly. It could break through that bone and it could cause nerve irritation. I have that happen on occasion. All surgeons do. The key thing is to address it. So if I have a patient that's having nerve pain after surgery, I'm going to get on it. I'm going to do it. I'm not going to put my head in the sand. I see a lot of surgeons do that. Oh, sorry, everything went fine with your surgery. It just happens you have right leg pain still. Sorry. No, we evaluate it. We get a CAT scan, make sure everything looks okay. We evaluate our screws very closely. On that CAT scan, we could also see if there's possible areas of nerve compression. So back pain, I would say, is much more challenging. So persisting back pain after surgeries. So you could have what's called a pseudoarthrosis. A pseudoarthrosis means that the fusion did not heal. So sometimes a fusion won't heal, and there's a number of different factors that can lead to pseudoarthrosis. And I believe on the one of the next couple of slides, we'll discuss that further. You can have loosening of your implant. So if the fusion doesn't heal, those screws and rods are an internal brace. There's a lot of stress. They can weaken and erode the bone and become loose. And that in itself can produce more pain. Adjacent segment degeneration. So we have one fusion. The surgeon, with the techniques they use to do the decompression, removes a lot of structure above, and can result in early adjacent segment degeneration or arthritis. Like I said earlier, he might just have back pain because you have back pain. Surgery is not a great cure for back pain in general. And your fusion was done for a bad indication. If you had a fusion surgery done with hopes of curing your back pain, and you have fibromyalgia, you've been on narcotics for 5 years, and you still have pain after, it's a very challenging scenario. And another surgery might not be the answer. The best answer would have been not to have that first surgery, but unfortunately you did. And tough. There might be some other options though for treatment, which we'll go through. So in terms of pseudoarthrosis, where a fusion doesn't heal and leads to risk for possible loosening of screws, things that I see as risk factors are minimally invasive surgeries. Minimally invasive surgeries, yeah, they're very sexy. You'll see, if you go online, you'll see a lot of minimally invasive surgery advertised. You see it advertised, on our TVs in Orlando, on a daily basis. Um, but when there are fusion surgeries performed through minimally invasive techniques, it leads to really poor carpentry. You don't clean off the bone surfaces as well, and it leads to a higher rate for pseudoarthrosis. So it's I see pseudoarthrosis very commonly with minimally invasive surgeries, and I fix a lot of surgeries, minimally invasive surgeries that didn't heal. Multi-segment fusions. So the more fusions you're trying to get to heal, the more likelihood there is for a failure. And then some of the surgical techniques, particularly if you're doing a long fusion, there's certain areas in the spine that we have struggles with fusion occurring, particularly at lumbar 5, sacral 1. And if the surgeon doesn't do enough work at that area or do the right type of screws, or if you have poor bone quality, it can definitely lead to failures. So if you've had a fusion surgery, you're still having pain, what do you do next? I would say one, you go back and see your surgeon, you see what they say. If they tell you everything looks okay, or even if they don't tell you everything looks okay, you can consider getting a second opinion. And I think a second opinion is wise for most people with persisting pain after a fusion surgery. And then it's important to get the appropriate imaging studies. So if someone has nerve pain, radiculopathy, we want to do an MRI scan. Issue is with metal in the spine, the metal can distort the imaging for an MRI, and sometimes we have to do a different study called myelogram CT, but that's a small procedure where we have a radiologist inject dye into the spinal fluid and then do the CAT scan. It doesn't have as much issues with the metal artifact. If someone has back pain alone, so no nerve pain, we really don't need that MRI. We really don't need that myelogram. We just want to look at the screws, the rods, and the fusion and other areas of arthritis, which we can usually see pretty well on just a CT scan. So over here on the right, this is a CT scan. This gentleman had a fusion surgery performed. I think his fusion surgery was performed about 9 months before we saw them. This is a CAT scan. So here is one of the screws. So here are screws. So you're seeing on a CAT scan, not seeing the entire screw, but this is a cut through that screw. This screw looks fine. We see the screw, which is the dark white, and adjacent to it is a gray, which is normal bone appearance on a CT. Whereas this screw, you see a dark halo or ring around it. So that means that screw has eroded the bone. So this screw is very, very loose. We see that there's a failure of the fusion hasn't healed yet here. Fusion really hasn't healed much here. There might be some good fusion here between 4 and 5. Options for treatment are to evaluate possibilities for more surgery, pain medications, pain injections, physical therapy, a TENS unit. So I would recommend you all look at a TENS unit. It's very simple technology to use, a little device that you wear with electrodes on your back. That electrical stimulation can confuse your spinal cord and pain, spinal cord and brain about pain. It disrupts the pain pathways in the spinal cord. A spinal stimulator is an internal version of that, so that can be more convenient for patients. These electrodes get placed internally in around the spinal cord, and then a battery pack gets installed underneath the skin. And so it's very convenient. The patient doesn't have to worry about wearing anything. Stimulators can last 3 to 5 years. The batteries, they can be interchanged. It's in closer proximity to the spinal cord, so it might be more effective. In extreme situations, an intrathecal pain pump. So instead of taking morphine by pills and having the medicine go throughout your whole body and producing side effects, constipation, they can deliver a very small dosage into the spinal fluid through an intrathecal pump. Not something that I do, but it's something that pain doctors can do. And then another option is to live with it. So I tell a lot of patients to live with it. I present them with options. I say, here are your options, and live with it is usually an option. I saw a gentleman today, a really nice guy, um, had a complex problem, had a fracture, had nerve compression. He had a combination of back pain and sciatica. And I told him 6 months ago, I was like, um, one, we tried everything we could. We tried injections, therapy, he wasn't getting better. So I offered him a decompression surgery, create room for the nerves. Told him, I think it's going to help with your leg symptoms, but you still might have back pain when we're done. And that's kind of the case. We fixed his leg pain. He still has back pain. And now he's back. And I'm like, all right, our next step, if we do another surgery, is a fusion. And I can't guarantee you that that fusion is going to cure your pain. You've already had a fracture in your back, so I think your bone quality is marginal. And so there's a higher risk in your case of this fusion surgery, maybe causing more harm than good. You can end up with screws that are loose and actually end up with more pain long term than less pain. So living with it can be an option. It's not a great option. None of us want to live with pain, but sometimes it might be the best option. So with MRI scan, so like I said, MRI, if someone's had a multi-level fusion or a fusion multiple segments, so this is an MRI on the right side of your screen there. These are the screws, the dark, and the screws just distort our image. It gives us what we call metal artifact, and therefore a CT myelogram that provides us with a lot better instrumentation. I can see the screws, I can see the bone, I can see if there's screws that are loose. Um, I can see the nerves and sac. Is there spinal fluid where it should be, or is there nerve compression remaining? So sometimes it takes a more advanced study, an invasive study called a myelogram, to find answers for some patients that have had fusion. Here's the spinal cord stimulator. So it's a similar technology to the TENS. It involves electrical stimulation that confuses the spinal cord and brain about pain. This is how it would look. This is the battery pack. The electrodes get inserted into the spinal canal. This is usually initiated through a pain office, a pain provider practice. They usually work up the patient. There's a whole protocol you have to go through. They start out with a trial that's done by the pain doctor where they insert the electrodes. If that trial works, they usually refer on to a surgeon. I don't do it. There are other surgeons in most communities that implant these stimulators. So that can be an option for some patients. I would say it is better for leg symptoms, nerve pain symptoms, than back pain symptoms. But some people do see improvement with back pain. There are some new studies that suggest there's some special stimulators, what we call low frequency stimulator, that can provide relief for patients with back pain. So you're seeing a patient with multi-level disc degeneration, arthritis everywhere, and back pain. Instead of doing a big surgery, maybe consider a spinal stimulator. But there are risks. So when these electrodes get placed into the spinal canal, it is possible to see spinal cord injury. Usually it results from bleeding occurring while the electrodes are placed. I've been in practice for almost 20 years, and I have seen maybe 3 or 4. I know at least 3 patients that had spinal cord injuries occur with the stimulator placement. But that's out of thousands of patients that have had these devices placed in my communities. And usually those patients have recovered when they're taken urgently back to surgery. As soon as their weakness is noted, they get the spinal cord decompressed. But there are some risks associated with a spinal cord stimulator, so it's not something to take lightly. And you consider, do you live with it or have this procedure that could potentially result in a spinal cord injury, although rare. So I just want to go through, I think I've got 3 or 4 cases here, some examples. So this is a 63-year-old gentleman. He presented in my practice my first year here in Orlando, and he had a fusion performed for back pain and sciatica. It was performed about 9 months before he saw me. Said he did well for about 2 months, but then had back pain return. His leg pain and sciatica didn't. He completed physical therapy, no improvement, and he returned to a surgeon who said, "Everything looks good. I don't see anything else I can do." But he had disabling pain. He was pretty frustrated that, in fact, main thing is he couldn't golf. Um, and so he showed up at my office. We shot X-rays, and I walk in, and I'm like, "Did you know you have broken screws?" And he's like, "What? My surgeon said everything looks good." No, it's pretty obvious. So here you can see this is what we call the screw head. So there's a gap there. So both of these screws are broken. meaning that there's no stability there. They're not providing the internal bracing that we need. And usually, if you see a screw screws that are broken, it usually means that the fusion didn't heal. So on this X-ray, I can't tell that the fusion didn't heal, but we do a CAT scan. So here's a CAT scan. So if this was a fusion, we would see solid gray growing with bone growing across this device. Where here we kind of see the device, see these large gaps, so there's no bone crossing that area. So it's a definite pseudoarthrosis or a lack of fusion. So what we did for this gentleman is we took him back. We did a two-stage surgery. It's one surgery for him, one anesthetic, but 2 stages for us. May have been 3 stages. I'm trying to remember. Sometimes I start out by taking the screws out that are broken. So we take everything out. Then we turn them over. I do this usually with a general surgeon, a vascular surgeon. We come in through the front. I take out the cage that never healed. I put in clean out the surfaces of bone. So do some better carpentry. So he had a minimally invasive technique the first time. It sounds real sexy to do it through a small, tiny tube, but problem is trying to be too sexy results in poor carpentry and poor healing. So we took out that small device that was placed with his minimally invasive surgery. We cleaned out the surfaces of bones to create an environment where bones are going to heal better. We put a large graft in with a lot of surface area, and we also added a plate onto the front, provide more stability. And then we replaced his screws and rods in the back with new screws that were intact, so to provide a new internal brace. And he did extremely well. His pain went away. He was very grateful, very nice guy. He subsequently referred us a number of patients, and he returned to golfing. I think we let him start swinging, chipping, and putting about 3 months after surgery, and he was really eager to get back out to the golf course. Here are some more challenging cases. So this 66-year-old female, so 2008 to 2010, she underwent 5 spine fusion surgeries. And then her last one, she had a wound infection, and then she had persisting pain. She was disabled. I mean, this lady, she was on bed rest. She was miserable, just 24/7, bed rest, couldn't sleep. Told by her last surgeon nothing else can be done. Here are x-rays. So they did a big deformity surgery. She's still leaning forward a little bit. That's not really the source for her pain. Source for her pain is down here. So this is her, what we call a pelvic screw, which oftentimes gets placed with deformity surgeries. This is the ring. So there's no bone in that area. That screw is that loose. It's just moving everywhere. So this is obvious that there's a problem with this fusion, severe loosening of the instrumentation. Here's the CAT scan. So you can see there's just giant holes around the bone, around the screws. There's no bone surface there. And with her history and everything, it's very concerning for infection. So we started out, we we removed her loose screws. I was very high risk or high suspicion for infection. When we explored it, we got in there, we found active infection, we found pus. So basically what we did is we removed the loose screws, we kind of cleaned the infection up a little bit, put in some drain tubes to let infection out, treat her with antibiotics for a week before going back to redo the fusion, redo the surgery. And then she's on antibiotics for another 6 weeks after we revised her surgery. We did a technique. Her case was the first case that I ever did this technique, and we described this for other surgeons, so it's now used around the world, where we put dual screws into the pelvis and the sacrum. We did keep her on bed rest for a little while because we were very concerned about her bone quality. So these are the screws. So very long anchors that we put down into her pelvic screws to really get good bone. They use something called spinal navigation, where we do intraoperative imaging, intraoperative CT to place these screws so we can know precisely where these screws are going. And she did remarkably well. She was one of my more gratifying cases. She went from disability, being told she was a chronic pain problem, to a normal lady getting back to a functional lifestyle. But this isn't everyone. It's not everyone that's had a fusion that has persisting symptoms that we can cure. So this next one's a 66-year-old male. He's had seven surgeries. Unfortunately, these were performed by neurosurgeons who were really not experienced with major surgeries, major fusion surgeries, deformity surgeries. So there's a lot of times where I see surgeons get over their head. These surgeons should limit themselves to decompressions, 1 or 2 level surgeries, but for whatever reason, they just keep going at it and doing more surgery and more bad surgery. So his biggest complaint is he can't stand upright. When he stands, he leans forward. I mean, he's like this. This is his head. He cannot stand up straight. You'll see by the x-rays. He has severe pain that goes into his legs. Anytime he sneezes or coughs, he's in agony. He's not the healthiest guy, as you can see. He has Parkinson's and some other issues, but he basically tells his family, we're doing another surgery with this guy, or I'm going to die. You're just going to let me die because I can't live in this pain. Here is x-rays. This is just a mess. So they've got some screws and rods here, one screw there, no rods. Like, I don't know what they were thinking, honestly. It's an absolute disaster, an absolute mess. And then you can see this is him trying to stand upright. So his head should be up here where my arrow is. Instead, his head is way here. Like he is honestly like that, trying to stand and walk. And as you can imagine, you can only hold yourself there for a very short period of time before you're going to have pretty disabling pain. So this was a no-brainer. I saw this guy in 5 minutes. I said, "You need another surgery. I mean, you can't live like this." And he agreed, and we did a major surgery on him. Did what we call osteotomies, where we fracture and remove bone. Um, and we were able to get him standing up pretty erect. He's not perfect. He still leans forward a slight bit, but he's not at a right angle. We have him up pretty well, and his pain has dramatically improved, and he lives for a number of years pain free. Despite having 7 unsuccessful surgeries, sometimes the 8th surgery can be a miracle. Another kind of tragic case, 53-year-old lady who was normal, goes to her doctor, has some neck pain. The surgeon says, well, there's an abnormality in your neck, concerned it could be cancer. Instead of doing just a needle biopsy, they do an open biopsy and they put screws and rods in fusion. Probably not the best reasons to do the fusion. The pathology says there's no tumor there, there's no abnormality there at all. So it's probably just an arthritic condition. She comes back, has more pain, and develops kyphosis, where her head and neck is leaning forward. They take her back and do a second surgery, in my opinion, a second very bad surgery, and leads to more problems. So over the next 2 years, she has more deformity and ultimately ends up with a chin on chest. So her chin is stuck down on her chest. She cannot lift her head upright. She cannot look forward to walk. She cannot lift her head up to eat. Leads to a lot of swallowing problems. And she also is having more trouble with her balance and coordination, concerning that there could be some spinal cord issues. So this is this poor lady. This is her trying to lift her head up. This is the best she can do. So her chin is stuck on her chest. And these are the bones in the back of her spine. These aren't screws and rods. These are the bones, your normal bones that you have. You can actually feel back here. But as your head leans forward and that skin gets stretched over those bones, they protrude through they don't usually come through the skin. Occasionally they can come through the skin, but usually they protrude, and patients don't like the way they look. And obviously it's quite disabling to have your chin stuck down on your chest. So here are x-rays basically showing that her chin is on her chest. This is her trying to lift upright so she can get her chin about an inch off of her chest. So pretty sad state of affairs. And she has some spinal cord compression here. So this is the base of her brain. There's her spinal cord. It's pinched from arthritis occurring because her spine is left leaning forward. Very poor mechanics. So for this lady, did a pretty extensive surgery. We went in and we took all of her screws and rods out. We basically undid her fusion, any areas that were fused. We undid that with what's called osteotomies, where we remove bone and joints to kind of loosen the spine up so we can try to put some of that normal curvature back. We staged this, meaning we did this surgery, and then we planned on bringing her back and doing a second surgery. We put her in traction for a day, where we're hanging weights off her head to try to improve the alignment of her spine. And then we came back and did an extensive surgery through the front of the neck and through the back of the neck, with grafts and plating through the front, screws and rods through the back. And this is how things look after. So now her chin is no longer on her chest. Okay, so we've got her head looking upright. Here we can see the plate in the front, the screws and rods in the back. And I just saw a car pull in my house, so I know you're going to hear some dogs going crazy in about 30 seconds, but we'll keep rolling here. So here's her post-operative CAT scan. So this is before. You can see how she's leaning forward, and here's after. We have her neck back in a more normal alignment, and this is her 2 months after surgery, extremely happy, smile, swallowing. There's the dogs I warned you about. Um, but she had, I mean, just a very gratifying case. She still had swallowing problems, but her pain was much better. Her quality of life was much better. She was able to look forward. So, in summary, um, be cautious, buyer beware. If you're advised to have a fusion, try to make sure that it's being done for a good reason to have that fusion. Understand the implications of having a fusion. So with a fusion, we're sacrificing flexibility and sacrificing movement. Is your surgeon experienced to handle complex cases? So if you're having a multi-level fusion procedure, in those cases, I definitely would recommend you get second opinions and make sure that you're having the right thing done. These cases are complex. These cases have a high rate for non-healing, and there's certain techniques that are going to improve the likelihood for success of a fusion and successful relief of your symptoms. Like I said, consider getting second opinions. If you have persisting pain after fusion, return to your surgeon, ask for imaging studies, ask for options. If you're not getting the answers you need, consider getting second opinions. Explore your options. So, is it revision surgeries? Is it pain management? Is it both? Consider a spinal stimulator. And if you run out of options, a spinal stimulator. And I think if you've seen a few very high quality spine surgeons with good track records, good reviews that have told you nothing further can be done, you probably need to listen to them and maybe consider a spinal stimulator. Or if you're not the healthiest person, you had a fusion, didn't heal, maybe consider a spinal stimulator versus a risky second surgery. Or if you have some chronic pain factors. So if you're a patient that's had fibromyalgia and pain and thought a back fusion surgery was going to cure that pain and it didn't, maybe not have that next surgery, even if there's a prior fusion, maybe consider something like the spinal stimulator or living with your symptoms. Surgeons and fusions don't always cure pain, particularly back pain, particularly neck pain. So buyer beware. Thank you all for your attention, and I'd be happy to answer any questions you have. Are you there, Melba?
Yes, I am. I don't see any questions on the queue yet.
All right, we'll give it a couple minutes.
All right.
We'll stop sharing. There we go. So if any of you are interested in, if you've had a surgery, it hasn't turned out the way you want to get a second opinion, um, you can certainly call our office, request appointments. A lot of times we do have you see one of our spinal PAs. So we have a number of physician assistants. They are outstanding. Okay. I know patients have some reservations about seeing physician assistants. My physician assistant, Colin, has worked in spine for about 10 years. He knows what to do, what studies need to be done. He's going to get everything set up for you to come and see me. He's going to make sure you have all the appropriate studies. He's going to lead you in the right direction. And we have other PAs, Ashley Grable, Ian Ortiz, fantastic individuals, know what they're doing with the spine. So they know more than your primary care physician when it comes to spinal conditions. I assure you, they know more than most other physicians. So please don't have reservations in seeing a PA for your initial appointment. It really allows for efficiency. We get you in quicker by seeing a PA. They order the appropriate studies, and then you're going to see a surgeon or a pain provider shortly thereafter. And it really improves the effectiveness and efficiency in our practices and allows for us to see and treat a lot more patients. And Melba just posted a phone number for appointments and her personal email. Oh, you're a brave soul, Melba.
I am. And believe me, people do write to me.
I'm sure you do. I'm sure you do. Good and bad, I'm sure. I saw
More
that, Dr.
good.
Fassett.
Well,
So, and
Dr.
then it's
Fassett,
not,
I see
and I
three
just want to,
questions coming up.
okay, sounds good. I was just going to say, we might see you and I might tell you, I don't have anything to offer you. I don't have anything further I can do. And unfortunately, that is a sad state of affairs that there's sometimes some people have had fusions, some people have had, have chronic pain and we can't fix it. But having another unsuccessful surgery isn't the right answer. I have patients get very upset when I say, I don't think I can help you. If there's a solution, I'm going to usually offer it to you. I'm going to present you with options. But sometimes I don't see a surgical solution. And I think it's best to see an honest surgeon and get that honest opinion rather than rushing off to surgery and, helping your surgeon pay for his Lamborghini payment or something. I'm a Honda driver myself. All right, let's go on to the questions. I don't see them, Melba. Do you?
I
All right, there are
do.
questions. I got them now.
Do
Okay.
you see them? Okay.
So there's Catherine. Hey, Catherine, how are you? I know Kathy very well. Will you have erosion over time or not if you have good bone growth? So if you have a solid fusion, it prevents the screws from coming loose. So I do see some patients that can have screw loosening or a screw breakage and their fusion still heals. But in general, so if you're a year out from surgery and you have convincing fusion, the likelihood of a problem with a loose screw down the road is dramatically decreased. And I hope you're doing well, Kathy. Good seeing you. Um, Next question. If your MRI shows stenosis in multiple cervical levels and pain is not the issue, but ataxia and weakness is a problem, would you recommend surgery? I would say if your spinal cord is compressed and you have symptoms of ataxia and weakness, usually I would recommend surgery. So that's what we call myelopathy. So if someone has those problems and we think that the compression on the spinal cord is damaging the spinal cord, we usually recommend surgery. Now, there can be situations where a patient might have mild or moderate stenosis, which is really not causing damage in their spinal cord, and they can have ataxia and weakness for other issues. So they might need to see a neurologist, have nerve testing performed, look at their brain. There's a lot of different possible causes for ataxia and weakness, and spinal cord compression and spinal cord damage is one of those. So, but yes, if someone has stenosis that we believe is causing spinal cord damage, we would usually recommend surgery. Do you recommend bone building medications of spinal fusion failures? Well, usually by the time the spinal fusion has failed, it's too late for the bone building medications. So what we try to do is evaluate and consider those things before surgery. So if we're seeing an older lady with a scoliosis that needs a fairly extensive fusion, um, we want to assess her bone quality, and if she has severe osteoporosis, consider some of those medications to possibly strengthen her bones before she goes in on that fusion. So her bones are stronger, can hold the instrumentation, improve our likelihood for a successful surgery. If someone has a failure and we find out they have osteoporosis, treating the bone quality is probably too late. Before doing a revision surgery, maybe treat the bone quality. I've had a discectomy with fusion of lumbar 4-5 and L5-S1 9 months ago. Numbness in both thighs continues and pain has gotten worse. Any suggestions? I would say you probably need some new imaging studies. In your case, I would probably start out with an MRI scan, a non-invasive study, and see if there's any problems either at those levels where you had surgery, or even within 9 months of surgery, you can have an adjacent problem. So you could have a problem at L3-4, arthritis, or disc herniation that's causing nerve compression. If the numbness is in the thighs, it could be something else called lateral paresthetica, neuralgia paresthetica, lateral femoral cutaneous nerve syndrome. There's some other possible etiologies for that. So, but I think getting some imaging studies, getting a new MRI scan, a CAT scan, maybe even a CT scan to assess the screws and rods. All of those things could be consideration for evaluation. I've had a fusion, continued back pain, and resulting foot drop. That's a tough one. So I do see some patients that have foot drops. I've had a patient, it's pretty rare, develop a foot drop after surgery. I've seen a number of other patients have foot drop from very poor surgeries where screws go through nerves. So I would say, Alan, you probably need a CAT scan, maybe an MRI, need to see where the screws and rods are. If your foot drop has been a long time, then it may never get better. Although I've treated some patients that have been 2 years out on foot drop and it's improved. Um, but you probably need some studies, a CT scan, an MRI scan, possibly a myelogram. You just have to see, but you need some studies to evaluate what's going on and see if there's what your options might be. All right. Well, I hope you all enjoyed the session and found it informative. And thank you again, Melba, for arranging all this.
Thank you, Dr. Fassett. Have a good evening,
Everyone
everyone.
have a good night. Thank you.